Hi, everyone. Welcome to another Wednesday VMR. Sharmin here. Um, I'm very excited for many reasons. First, being here, obviously. Second, I get the pleasure of discussing with one and only Laura. Laura, how are you doing?
Hi everyone. I'm doing so good, and it's even better that now that I can get a chance to discuss with the true legend of the space, one of
I
the
don't
biggest brains
know.
of the CP solvers.
Oh, I don't know about that. Probably the most excitable one, but that's also, I feel like Rez would take that as well. Anyways, I appreciate the love. Thank you so much. CP Solvers is honestly amazing because of all of you. A big shout out to Glenn and David for teaching points and scribing. And we have a first time case presenter. Daniel, thank you so much for joining us.
Oh, of course. Thank you for having me.
Yeah. And David, you got to introduce yourself to the big group and also tell us something you like to do outside medicine.
Okay, so my name is Daniel, and I'm a fourth year medical student, and I'm in a medical school in California, and most likely going into internal medicine. And something I've been doing more of lately is I'm playing more golf. I used to play a lot more in high school,
Nice.
and then I took a big break from it because I wasn't as good as I thought what I was going to be. But now I'm getting back into my roots of playing more golf, even though I can't practice that much. I was like, that should not be an excuse for me not to do something that I enjoy.
That's amazing, Daniel. And kudos to you for trying to get back into and keeping those hobbies is really, really important. And I completely agree. I think Prof. Rez somewhere in this universe is smiling upon you for doing golf, which is pretty cool. All right, everyone. If you can get the board up, we'll get started.
Okay. So one thing is, so we have a power outage. So I'm on my hotspot. So if at any time my connection gets weak, just let me know. I can try turning off my video. Okay, cool. So we have, this case will have five aliquots, and then I will reveal the final diagnosis afterwards. We can go ahead and start with the first aliquot. We have a 51-year-old male presenting with chest pain, dyspnea, and right upper quadrant pain.
What an interesting start. Mainly because the aliquot didn't end where I was expecting it to end. I mean, we quite often deal with chest pain and shortness of breath combination, but not so often with chest pain plus shortness of breath plus another source of right upper quadrant pain, which kind of makes me right from the start consider if the primary pathology is actually in the chest or is it in the abdomen, because right upper quadrant pain is quite close to the diaphragm, which can also present as pleuritic chest pain due to irritation. But the presence of dyspnea is definitely a balancing feature between the two portions of the diaphragm in the human body. So I think basically with the chest pain, when we think about chest pain, we think of what can be hurting inside the patient's thorax. And something that we like to use here is the chest pain sandwich. Basically, we have the lungs in the thorax that are by themselves painless, but we have things overlying the lungs from the outside, like the pleura or the chest wall, which can definitely be painful, and also from the inside in the form of, but basically everything that's in between the lungs, which is mediastinum and the heart mostly, which can also be quite painful, as we know. I think the most morbid thing that I would be worried about would be the heart pathologies. So I'll right away order an EKG and check troponins in the patient. And the presence of dyspnea makes me even more concerned about the heart pathology going on, but also makes me stop and think, yes, like the pulmonary processes can be painless, but the pulmonary processes can also rise to the outside and irritate the pleura. Um, so this would be another possibility that I would consider. So I think I would also be ordering chest X-ray at this point of time to also check if there is something going on in the lungs. But I'm definitely less worried about them than I'm worried about the heart in this patient. And the right upper quadrant rate is so interesting. Potentially, it could also be the other way around. This patient is having an acute thorax syndrome, and there is irritation of the pleura on the right side, and it's just interpreted by the patient as right upper quadrant rate. But I think we would definitely need to specify what the patient means by this pain. Like if there is any evidence or hint toward the pleuritic nature of the pain, if it's worsened on the inspiration with the deep breathing, then potentially it's something going on in the thorax, and the dyspnea is really makes me worried about the thorax rather than the abdomen. But we also know that there are a lot of diseases that can disseminate from the abdomen to the thorax. So there's this pathway that I would be keeping in mind as well. But yeah, another interesting confiner here would be the time course of this. Like, does all the three complaints happen all at once? Were they acute? Were they subacute progressive? One happened after the other. So this would be the evolution of the disease will be quite helpful in establishing the primary source of pathology in this patient. What do you think, Sharmin?
I just love listening to you reason. That was beautiful. That was so thoughtful, so thorough. I really, really love that. When we hear all of these complaints, the one that, could be the most morbid, as you mentioned, is a chest pain, thinking about ACS or at 4+2+2. So, that we love at CP Solvers, and like kind of thinking about how those can be all related to each other or unrelated. And, as you mentioned, we have like three of like really common etiologies we see with very broad differentials, like chest pain, dyspnea, right upper quadrant abdominal pain. And I'm totally there with you about like it's really hard to make any diagnostic progress here. It's way too broad, and we have very little information other than like all these three subjective symptoms potentially have all like significant no misdiagnoses that we have to worry about. And I think, as you mentioned, the most important thing that I would want to know is like, what is the time frame? Did this happen like few minutes ago, an hour ago, 2 hours, months, years? And as you mentioned, like which came first would be really, really helpful in terms of like helping us calibrate how many of those no misdiagnoses do we need to invoke, or are we potentially dealing with like a more subacute or chronic processes? Whatever has happened has led to this patient showing up to get care for these things. So there might be a potential acuity going on. But in terms of like your thinking about like the etiology that you invoke, I have absolutely nothing to add. It was absolutely joy to listen to you. Back to you, Daniel.
Okay, so the second aliquot, he reports a 2 to 3 week of intermittent sharp chest pain that's radiating to the left arm, and it gets worse with inspiration. He's unsure if it gets worse with exertion. He reports a 5-day history of dyspnea, worsening with exertion and lying flat. This has been progressing over the last 5 days. Furthermore, he has 9 out of 10 right upper quadrant pain, worsening over the last 5 days, peaking about 3 days ago with nausea and vomiting, along with subjective fevers and chills. He had another episode of emesis last night, which was non-bloody. He reports similar right upper quadrant pain during a prior admission at an outside hospital 3 weeks ago and was told that he may need a cholecystectomy. For review of systems, he was negative for lower extremity edema, palpitations, syncope, diarrhea, and constipation. Negative for all of these. And then for past medical history, he has congestive heart failure, which was diagnosed also 3 weeks ago at the outside facility. He also has hypertension and history of long-term meth use. He stopped a few years prior. For meds, it's unclear if patient is on GDMT for heart failure. We didn't have access to his medical records, and he reports that he was given a quote-unquote water pill 3 weeks ago. For social history, he's been smoking a quarter pack daily for 25 years.
Yeah, thank you so much, Danielle, for this information. And now we have more clarity on what happened first and what happened after that. And it sounds like the first came the chest pain, which kind of sounds more both concerning for pleuritic nature, but also for the myocardial nature. And with the most morbid one being the myocardium, I think we definitely are still waiting for troponins and EKG in this patient. But it definitely could end up pleuritic as well. We just need to rule out the most morbid cause first. And then came dyspnea and abdominal pains in this patient. So the progression from the chest pain to dyspnea is quite interesting. And also the description of dyspnea, which is worsened with lying flat, is quite interesting as well. Because it could be that the myocardium is affected and it's affected and being progressively affected and destroyed by a few weeks of disease going on in this patient, that it just got weak. And we also have some history of congestive heart failure in this patient, although we're not clear how this diagnosis was made, because at least for now, we don't see quite a lot of objective evidence of heart failure exacerbation. This patient don't see lower extremity edema and don't have enough of objective findings to say that the orthopnea that this patient is describing is truly related to that. But potentially, still myocardium can get so weak and already vulnerable myocardium that the dyspnea in nature is just basically a venous congestion of the lungs and orthopnea, which is quite classic description for the dyspnea being worse with lying down. But another possibility here is that to rule out mimics, because, for example, we already have a sense that the chest pain sounds pleuritic in nature, and we already know from the studying, I guess, that when we have a typical pain for pericarditis, it gets better when the patient is lying forward and worse when he's lying down. So pleuritic pain from pericarditis can quite well mimic orthopnea in this patient. So I would definitely want to listen to the lungs. If I hear any crackles, I would be definitely worried about true orthopnea here. But getting mimics ruled out and keeping them in mind would be also helpful. Yeah, I'm not sure yet how to connect the right upper quadrant pain and the inflammatory nature that the patient is describing, but inflammatory nature could definitely speak more about the potential serositis going on in this patient and less about something vascular like ACS, which we're worried. And the time course of 3 weeks also speaks quite against that theory, but it's still so morbid that we need to rule it out. Potentially, if when the heart is connected, is basically the center of the gravity in human body. So we know that there is such entity as ischemic hepatitis, for example, which can be secondary liver manifestation of the problems in the heart due to venous congestion. But I'm still not sure what's going on in the liver, and I would definitely want to see the liver function test to check for liver damage and potentially also do some imaging based on the results that we're going to get. Curious, what do you think, Sharmin?
Oh, just absolute masterful dissection of all the information provided. I totally agree with you. Daniel, can I just clarify something about the history? So it sounds like he was hospitalized 3 weeks ago and was diagnosed with acute cholecystitis and heart failure at the time. Is that accurate?
So we are actually unsure. He
Okay.
said he showed up to the outside facility 3 weeks ago because he was having difficulty breathing,
Okay.
and he was given the water pill along with he was unsure of his medications, but it sounded like possibly GDMT.
Okay.
Um, and then they said something about his gallbladder and that he needed to get his gallbladder removed, but he was unsure about why.
I see. I see. That's super helpful. Thank you so much.
Mm.
Yeah, it's even though that we have more clarity in the time course, I totally agree with you that I don't think in terms of like the differentials you were entertaining, there is much change to them. There's like multiple different ways of like putting this patient together, and like oftentimes we want to like connect all of them together. I usually try to resist them and think about like the chest pain, the orthopnea, and also the right initially separately just to make sure I'm not missing any pathology that doesn't, fall into the Venn diagram of like dyspnea, chest pain, and right upper quadrant abdominal pain. Um, yeah, so, w- w- what we know about this patient is that, like, most likely he has some cardiomyopathy that he's been told recently. Oftentimes, when we think about cardiomyopathy, what are the kind of the etiology of the cardiomyopathy? In the United States, like ischemic cardiomyopathy is probably one of the most common etiologies. So, as to your point, Lara, like needing to get the ECG, the trope, to make sure we're not missing like an acute coronary syndrome, it's very, very important here. The other thing about like the inflammations is that like, oh, what we know that he may have some gallbladder pathology, whether they saw stones there and now we're dealing more of an acute cholecystitis. The inflammatory processes can also invoke myocardial infarction, worsening cardiac symptoms, anginal symptoms. So it's hard to know which came first, but I think it's totally fair to be like, hey, this patient has inflammation. I have right upper quadrant abdominal pain that I'm worried about infection in general. And so we're going to do a thorough infectious workup, make sure we don't have any we're not dealing with the ACS. At the same time, the other thing is like, from if someone who's recently been hospitalized are thinking about like pulmonary embolism that could potentially cause chest pain, dyspnea, and exertion, or also like if he has like worsening right-sided symptoms that can cause congestive hepatopathy at the same time that can have like worsening right-sided heart failure. So there's so many different ways of like trying to connect these two or like keep them separate. So I totally think like exam would be really helpful. Are we just to make sure, in someone who has both kind of like smelling like the cardiopulmonary syndrome and potentially intra-abdominal process, or as you mentioned, these times still might be connected, right, by a pneumonia in the right lower lobe. And I love the thought of like pericarditis and myopericarditis for sure. So I think exam, just making sure like how sick is this patient? Is this someone that we are worried about shock physiology? And keeping a close eye on that blood pressure. If you're seeing narrow blood pressure, that make us more worried that there might be a component of more cardiogenic going on. Are there cold or warm on exam, fevers, or any like a specific exam finding that help you clue in about like if are there like crackles on the exam, or is this like Murphy signs on physical exam? And as you mentioned, like getting those initial lab work, it will kind of help us like parse out through like what is the number one problem here, because right now I don't know what the number one problem is. Is it like an infectious etiology? Is it more of a cardiac etiology? So I'm in the hunt to better understand what problem I'm trying to solve. Lara, any additional thoughts?
No, absolutely nothing to add to you. It's just, yeah, I'm still really worried about the heart being the center of gravity in this patient, especially with the dyspnea and exertion that basically we like to say that the exertion is not so a stress for the lung organs by
Mhm.
themselves, but more so for the cardiovascular system. So, yeah,
Absolutely. Yeah,
absolutely
absolutely.
agree with you.
Yeah, until proven otherwise, you want to make sure that you've like kind of ruled out your no miss like cardiac etiologies, which is like your ACS. Like I would say, like pulmonary embolism with like right-sided features is is another one to kind of think about here. You want to think about, any like kind of vascular pathology. All right, back to you, Daniel.
Okay, amazing. So for the next aliquot, we have his vitals. His temperature is at 98 degrees Fahrenheit. Heart rate is 104. Respiratory rate is 20. Blood pressure is 140 over 96. For his physical exam, the relevant physical exam findings are he had a hepatojugular reflux and JVD present. Also tachycardic, no murmurs were appreciated. Patient was in respiratory distress, and this is at time of presentation at the emergency department. And no crackles were appreciated. And patient also had right upper quadrant tenderness to palpation, negative Murphy's. Labs at ED presentation, his sodium was 134, bicarbonate is 23, BUN 17, creatinine is 1.27, his bilirubin was 1.3, ALP is 180, AST 67, ALT 64, and then his troponin T was his first was 22.5, second is 20.8, which are both within the reference range, and his pro-BNP was 6,988, and we have no baseline creatinine or pro-BNP available. And then for his CBC, his white count was 9.6. Everything else was within reference range. For his ECG, findings showed possible right ventricular hypertrophy and no concerning features for acute coronary syndrome. Okay, I will stop there.
Okay, now we get more sense of what's going on. And with the objective findings of GVD present and hepatojugular reflex, which basically indicate that there is right-sided congestion going on, we're more worried about the heart failure in this patient. Although the lungs are clear, and which makes me more worried about not so much of something on the left side transmitting to the right side, but rather something in the lungs primarily or primarily affecting the right side of the heart. Although with the chronic, like long-standing heart failure, there can be quite a lot of compensation happening in the lungs, so that the crackles that we hear are not so sensitive in the long-standing heart failure because of like increased lymphatic drainage of the excess fluid. So potentially still chest X-ray would be helpful here to understand if there is kind of subclinical but radiologically imaging positive congestion in the lungs. But yeah, basically the tension point for me here is understanding which side of the heart is primarily affected in this patient, and why so acutely, because I wouldn't expect, although he got his diagnosis of congestive heart failure 3 weeks ago, I wouldn't expect it to progress so quickly in 3 weeks to such this point. So yeah, another interesting flavor to this is ongoing inflammation that we not quite see, but we get in the flavor of inflammation going on based on the patient's symptoms. And the inflammatory heart failure is quite an interesting space to be in. And I'm not quite confident to say concrete diagnosis at this point because we don't know where the primarily disease lives, in the lungs, in the right heart, and in the left heart, but potentially considering what etiologies can cause inflammatory heart failure. And I think I would just go from the layers of the heart. Whenever I hear inflammatory heart failure, my novice diagnosis would be infective endocarditis. And yeah, I would definitely want to do an echo on this patient to see if there's any vegetation going on. And potentially the liver could be also a site of metastatic infection spread as well. Yeah, another point, kind of the next layer would be myocardium, and we already kind of talked a little bit about potential of myocarditis or myopericarditis in this patient, which is quite a common cause of heart failure in young patients, which this patient is. He's just 50 years old. And although he has some cardiovascular risk factors, they're not as robust as to predispose him to severe atherosclerotic disease, but it's still on the table, of course. Yeah. Yeah. I'm just glad that he's not hypertensive right now, although he's tachycardic, which potentially can mean that he can be hypertensive in a few minutes, in a few hours, or in a day. So I would be closely monitoring the hemodynamics of this patient.
Yeah, Beautiful. You were right to worry about the heart being the center of gravity. And looks like, we're definitely getting a flavor of like right-sided heart failure. Has like elevated JVP, like a liver chemistry abnormalities. No, he's currently not febrile with a normal leukocytosis. However, as you mentioned, like some of the indolent infections can present very differently. Doesn't mean we're endocarditis is always like a great thought to invoke, especially if it led to any valvular pathologies. We didn't hear any murmurs, but for sure, like infective endocarditis is really good to think about. Daniel, did he smoke tobacco or meth?
He smokes both. So
He smokes
it's
both. Okay,
quarter pack daily for the last 25 years, and then
got
meth. He used to smoke meth daily for
it.
multiple years, but he quit like 2, 3 years prior.
Okay, gotcha. This is really, really helpful to know. So, in terms of like, hopefully, as you mentioned, like his blood pressures are stable. We're not really hearing any crackles. Again, from the data we have, I worry about kind of like right-sided heart failure and with like the RVH, um, in the ECG. The question is like, is this acute, chronic, or acute on chronic? Meth is such a terrible substance, unfortunately. And one of the biggest things it causes, like in terms of like dilated cardiomyopathy, is actually pulmonary hypertension. And I worry with people who have like chronic use for them to have like underlying pulmonary hypertension that can lead to some degree of right-sided dysfunction. I would say the most acute thing in this patient is getting a CT-PE protocol to rule out pulmonary embolism that can cause acute worsening of right-sided heart failure, elevated JVP, congestive hepatopathy, if we're like making those two things related to each other. And the nice thing about a CT-PE protocol that allows you to better visualize the parenchyma is not perfect because you're giving contrast, but if you're picking up like a bit of effusion, ground glass opacities, pneumonia. The other thing that I would like worry about whenever I see elevated JVP would be just making sure we're not dealing with like kind of a tamponade or pericardial fusion or like constrictive cardiomyopathy. So I totally agree with you about getting a formal echo. If you're doing it at a bedside, just like putting the echo probe and making sure we don't have any big effusions, that would be an emergency. Um, and in terms of like calling how fast we're calling a cardiology consult, and I think like your initial of like also getting we can always like start with chest x-ray as well, but I have a very low threshold in this patient to get a CDPE right off the bat. In terms of like other etiologies of like right-sided heart failure, left-sided being the most common cause, one of the most common cause of right-sided heart failure as well. If you just like really upon this point don't have that much left-sided, at least like the lungs don't seem as much crackly. However, some people put their volumes in different places. So I totally agree with you, Lara, that like left side is not off the hook yet, but we just want to make sure there's not increased pulmonary resistance that is putting more pressure on the right than the left. So that's kind of like what I would be doing next. A CTPE, a formal echocardiogram. I think like getting blood cultures in someone like that who knows your IVDU, but endocarditis in someone who has endorsing some fevers, never a bad idea. And then I think the question is like, would you still trend those TROP? They're very mildly elevated, but the setting of like elevated BMP, especially if this is like pulmonary embolism, um, it just kind of helps you kind of better understand the severity and like what type of intervention might be possible. We're not there yet. First, we have to make diagnoses, but that's another thing to keep in mind in terms of like the interventions down the road. All right, back to you, Daniel.
Okay, awesome. So the next aliquot, we have some imaging findings, and we do have a chest X-ray which showed cardiomegaly without any other acute abnormalities. And then we have a CTPE, which showed no signs of pulmonary embolism. And we also have a right upper quadrant ultrasound, which showed a thickened gallbladder wall at 8 millimeters with pericholecystic fluid, liver increased in echogenicity, no evidence of hepatic mass. Biliary duct measures 4 millimeters, no evidence of intrahepatic biliary dilation, and gallstones are not seen. For some reason, we didn't have a TTE at this point. The patient presented to the ED like 2 or 3 a.m. I don't think we were able to get a TTE at the point of admission yet. That would be it for this aliquot.
Yeah, what an interesting space. Another point that I just noticed on the vitals, looking back, we see a patient is significant respiratory distress, but yet his heart respiratory rate is 20, but his saturation is 97, which I wouldn't believe at first. And I think if the patient is able to, I would just love to put a pulse ox on this patient and walk with him, because he even tells us that his symptoms, his dyspnea, is mainly present on exertion. So I would expect some desaturation on exertion here to make it more objective as well. And the evidence of pulmonary hypertension and the story that we're getting is definitely concerning, because we see RVH in this patient, and it doesn't happen in one day. It means that the process causing increased pressures on the right heart has been going on for quite some time. But it still kind of is a question to me whether it's a primary disease progressing, starting to progress a few weeks ago, or is this new unrelated or potentially related acute thing happening 3 weeks ago that is now kind of is acute and chronic, as you said. And yeah, I didn't see a lot of pertinent findings on the imaging here, so we don't have a lot of explanation yet for what's happening with this patient. But the thickened gallbladder wall sounds quite interesting to me. And I'm not so worried potentially about acute cholecystitis, but definitely would get a surgical consult to understand if it's something that potentially should be considered here. But something that I was thinking about is potentially how to link a gallbladder pathology to the respiratory distress in this patient. And there is an entity called pulmonary thrombotic PTTM, basically, pulmonary thrombotic microangiopathy, which is closely related to the kind of sneaky mucous cancers and adenocarcinomas in this patient. And this thickened gallbladder wall sounds really concerning to me. And I would potentially be also looking at the notes of the outside facility where this patient was admitted before, and understanding why they really wanted to remove the gallbladder from this patient, because there must have been a reason to do that and to recommend this. So in this setting, when we don't have a clear explanation for why this patient is having acute pulmonary hypertension with acute respiratory distress, I would definitely be considering this entity, which basically means that there are small parts of the tumor traveling to the patient's lungs, and it mechanistically sounds a lot like PE, but the particles of the tumor are much smaller, and they travel more distally toward the capillaries of the pulmonary vasculature, and therefore they're able to cause a quite significant respiratory distress in this patient. And the time course is quite similar to what we see here is subacute and rapidly progressive respiratory distress with evidence of acute pulmonary hypertension. So I think I would be considering this, and I would wonder what thoughts do you have, Sharmin, how to link all the
That
findings?
is such, I wasn't even thinking about that. And that's such a great thing to bring up, Lara. Like, kudos to you. That's beautifully discussed. Yeah, very good reassuring that we, at least I'm not dealing with like kind of a massive PE. We can take a deep breath. So I think for me, still like pulmonary hypertension from his like history of meth use is like probably the one of the bigger driver of this presentation in terms of like his gallbladder. Oftentimes, right-sided heart failure can cause like edema of the gallbladder wall, like the fluid around it. So it most likely in a setting of like in this presentation is from his like cardiac etiology. However, could he have passed a stone for sure. The fact that we don't see any visualization, and I believe there was no bile duct dilatation for us to worry about, like cholelithiasis of some sort, makes me think that this is probably a sequela of his right-sided heart failure. The thing that, and also like his creatinine being a little bit more elevated, I'm like, oh, are we also dealing with like kind of a little bit of a cardiorenal? The part that I am puzzled that these people tend to have when we have right-sided heart failure, um, a couple of things that can happen is that they also tend to have a lot of like gut edema, so they don't they don't PO Lasix tend to not work really well in them. They also tend to have like significant, in my experience, lower extremity edema, and we didn't see that on exam here. Like I've seen patients have like really scrotal edema, lower extremity edema, in addition to like the congestive hepatopathy and like kind of cardiorenal. So that is like makes me a little bit pause. But what I want more than anything right now is an echocardiogram, to also make sure to look at the valvular pathology, like bad tricuspid disease can do this, a pulmonary hypertension, and then the gold standard is oftentimes a right heart cath to be able to diagnose pulmonary hypertension. And the question is like, listen, are we just like seeing, as you were mentioning, this like kind of a progression of someone who has like meth-induced like cardiomyopathy and right-sided heart failure, or is there another trigger? And I think your thoughts were spot on in regards to like other etiology that could potentially make this an exacerbations syndrome. So those are like I think like I'm still like very like keen on the eye. They tend to sometimes have ascites, so like putting a I wonder if in the right quad ultrasound they saw any, if they did a full abdominal to see like if there's any like ascites there as well. But I am really worried about the vasculature in the lung and his right-sided heart. Any other thoughts from you, Laura, before we pass the mic to Daniel?
No, I absolutely love the framing that some gallbladder pathology can potentially go to the lungs and affect the heart, but also the heart can affect gallbladder. Really like this framing.
Yeah. All right, back to you, Daniel.
Okay, so for the next aliquot, on further questioning, patient said he ran out of his medications he was given 3 weeks ago. He ran out a week ago. And at the ED, he was started on furosemide and metoprolol. Um, and he was also started on cefepime and flagyl. 8 to 9 hours after presentation to the ED, this is when I saw him, and he denies chest pain and dyspnea at this point. He does report an intermittent 2 out of 10 epigastric tenderness. On physical exam, I did not appreciate JVD or hepatojugular reflux, and there was also no lower extremity edema. The only thing pertinent was his abdomen examination, which was a mild epigastric tenderness and negative Murphy sign. Uh, at this point, no additional labs were drawn, and we were not able to get an echo on this patient. Actually, the patient wanted to leave AMA. Um, but before I give you guys more information and the final diagnosis, I'll stop here.
Yeah, very interesting space. And the fact that what potentially could be contributed to acute worsening of this patient presentation could potentially be that non-adherence with the medication, or basically the absence of medications here, and potentially also contributing factors you were mentioning, the gut edema, which can also decrease the absorbance of the medication and present with epigastric tenderness as well. But I'm still not confident that could this potentially explain this worsening of the patient? Would it be enough of the trigger, or do we need still to look for something else here? And if I were in this situation, I think I would still be looking for some additional trigger because of potentially removement of the trigger. Yeah. So I think with this like unexplained pulmonary hypertension, which is kind of sounds like acute progressive, I would definitely be wanting to do a right heart catheterization.
Yeah, I totally agree with you, Laura. It's like, it's a tough space to be, someone who wants to leave, and what we can do with the information we have so far. So I think a lot of it is just when patient wants to leave, like getting a better understanding as to why is it? Is there something that we can do symptomatically to help them stay, make them feel better? Is there any like psychosocial pressures at home, any life situations that needs them that they have to go, and just kind of leveling up with patients about like the uncertainty we have at this point that we don't know exactly what is going on. And he's been like he's I was in the hospital 3 weeks ago, and now he had to come back to the hospital. And like, what I would worry the most is that like if we don't really have a good plan of care going forward, that this potentially can happen again. That he needs, we haven't like tried to fix anything. In the meantime, like trying to get an understanding of like how well, trying to get an understanding of like if once he was like challenged with Lasix, I really like, did he put out anything? How is his exam looking? How's his JVP looking? But I agree with you that it's like hard to make any more diagnostic progress without being able to get an echocardiogram at least to see if there's like elevated pulmonary artery pressure is there. And I think like the epigastric tenderness, one thing that we'll always like want to make sure is like, are we dealing with pancreatitis or not? And I think like just in making sure in the history, is there any like alcohol use involved? That looking at the lipase to the initial lab to see that. Thinking about like any like peptic ulcer disease that could do it. We didn't hear anything about like history of a GI bleeding or any other like kind of epigastric pain before, and it's mild, so I'm not sure if that's noise or signal. And like I think what I would want to do most for this patient is, as you mentioned, if we can get the records fast enough to see if there was any like a further cardiac workup, and how did they diagnose the heart failure to begin with. If we have that information available necessarily in 3 weeks, I doubt much has changed. So that would be hopefully maybe enough to at least make sure we're on the right path and we're not missing anything. The other thing that, oftentimes it might not be the best or like the most elegant way of doing it, but if you're like short in time and you need to speed up, like thinking about like whether any intra-abdominal imaging would be helpful to make sure we're not missing any other pathology, that like the intra like luminal things we won't probably see, but anything else in the belly that might be contributing that we haven't been able to catch. But yeah, it's a really, really tough position to be. So I'm like very curious to see, Daniel, how did you all navigate that?
Yeah, so I too was very bummed that he wanted to leave AMA. He's been waiting in the ED too long, he said, and he was feeling better, so he just wanted to leave. I was actually in my surgery rotation when I was seeing this patient, and
Ah,
we were trying to determine, okay, is this acute cholecystitis or is this uh, something else that's not going to require surgery? So the final diagnosis was we gave him was acute decompensated heart failure with hepatic congestion. And this is considering the course of his disease. He did get better with treatment, especially his right upper quadrant pain. Along with there were no leukocytosis and no findings of gallstones in imaging, along with no history of cholelithiasis. So we deemed that hepatic congestion was more likely over acute cholecystitis. Um, and yes, the by the time the internal medicine team got to see him, he wanted to leave AMA. So unfortunately, we were not able to get additional information.
oh, what an educational case. I love this exercise that we went through, Daniel. Thank you so much for presenting. Laura, any additional thoughts? Brilliant discussion, friend, by the way.
No, absolutely. It was such a pleasure discussing with you and Daniel. It was absolutely top level presentation of a case. Even though it was your first case presentation, you did such a great job. I really couldn't tell it was your first time. It sounded like you were doing this every time before this VMR. So yeah, thank you so much.
Thank you. I appreciate that.
Yeah, no, absolutely. And yeah, I and it's very cool. to have like seen this case while being on your surgery rotation as well. And I think it's like totally fair for them to have like called just to make sure that, you know, we're not sitting on like an acute coli of some sort. And our surgeons are such expert diagnostician when it comes to those things. So like I always like appreciate their input on like abdominal pathology specifically. Um, and yeah, I think the diagnosis makes sense. And even though the patient is like feeling okay to leave AMA, like we don't have to be done yet. So I think like different systems navigate this differently, but like making sure that this patient at least have a close follow up. I would like consider like a Bumix in them that has like better gut absorption than like Lasix in general if there's still a little bit of volume up. Like, and I think like setting up like a close follow up appointment or to be able to at least like get him back on some of the meds and like hopefully getting an echocardiogram as an outpatient to better understand his heart failure in addition to management of that. So I can understand like hospitals are a frustrating place. There's so much lack of control. There's so much waiting around that happens that I can only understand is very frustrating for our patients. And even if they want to live against I don't like I started calling it like adjusted medical advice rather than against medical advice. So we still like can send people out with like medications that I'm all for follow up. Even though I hope he could have get admitted to medicine so they could like help him feel even more better. But the fact that you're right, the right upper quadrant got better after diuresis, I think, and he felt better. Um, I agree with that, and I'm still like puzzled by the trigger of it. Whether it was just kind of like not being able to take medications, or this is just what we're seeing a trajectory of someone who most likely has kind of like meth-induced cardiomyopathy, and he's just like getting worse. So yeah, very interesting. I hope he follows up. Any other thoughts or any other teaching you want to share, Daniel?
Mm, say I can share a learning point for me was I learned that like a thorough history and appreciating the entire clinical context is so important in medicine. Initially, when presenting, I told my senior that this was most likely acute cholecystitis. I was like, oh, right upper quadrant pain, nausea and vomiting, pericholecystic fluid or gallbladder edema and pericholecystic fluid. But I didn't pay attention to absence of certain key symptoms and findings, and also the course of a disease. So it's really teaching me that like most of the time, no single symptom or finding or imaging results are meant to be judges of whether a disease is present. All this must be appreciated like within the entire clinical context when making an argument for a disease.
Ah, beautifully said. Nothing to add that. That was beautiful. Thank you so much, Daniel. We can't wait to have you back. Laura, you're amazing. Such a joy to discuss with you. Thank you so much, David, for scribing. And Glenn, we're ready for teaching.
Okay, I'll be taking you through the teaching points. And thank you, Daniel, for brilliant presentation. Actually, it looked like you've been in the VMR for so long. How you um structured the case and how you shared your learning through the case. That's that's excellent. And also learned a lot from Sharmin and Lera. I think they actually diagnosed the patient in the third or fourth allocate there. Um, so starting over with teaching points, we started off with the chief complaint of chest pain, dizziness, and right upper quadrant pain. We thought of our 422 schema for chest pains to rule out um, heart abnormalities like aortic dissection, acute coronary syndrome, and then two ones from the pulmonary system, PE, pneumothorax, the life-threatening causes, and then we also wanted to link the right upper quadrant pain with the chest pain that could be irritated by the pleura, and from there we didn't have the timeline, and we wanted to know the timeline and to characterize the pain as well. Um, and then after getting more information about the timeline, we thought of myocardium abnormalities, acute coronary syndrome, cardiomyopathy. We wanted to rule out PE still. And after hearing about the past medical history of CHF, a lot of heart failure exacerbation, and to rule out pericarditis since the chest pain was positional as well. Then we went to the right upper quadrant pain, sort of just biliary disorders, hepatitis, and also um, heart failure as well, right side heart failure or uh, right lower quadrant pneumonia, which could explain all the symptoms. Then from the exam, we heard about the elevated GVP, which suggested more of right-sided heart failure. There was no crackles, suggest left-sided heart failure. And then from here, we thought of wanted to rule out PE, which can worsen right-sided heart failure. Wanted to get chest X-ray, formal echo, and also wanted blood cultures. Just we thought there could be inflammatory right-sided heart failure from infective endocarditis, so blood MCS would help with that. And then also learned that the patient takes Matthews, so we were worried about pulmonary hypertension, and we thought that could be the one causing the cardiomegaly on the HS X-ray, and also about the taking gallbladder wall and for the investigation, thought of cholecystitis or congestion from the right side heart failure, which was actually the diagnosis for the patient. For the renal failure, it's sort of the cardiorenal syndrome, and wanted to know more about the imaging, but due to lots of follow-up for the patient, we ended up with the diagnosis of just hepatic congestion causing all the symptoms from CHF that the patient was diagnosed 3 weeks ago. So thank you everyone for joining, and thanks again, Daniel, for the presentation.
That was awesome. Thank you so much, Glenn, for recapping the teaching points. Thanks, everyone. Really appreciate you. Hope to see you soon, Daniel. Bye, all. Thanks, Laura. Bye.